Hello friends, welcome to the Emergency Medicine channel. Myself Dr. Ashik Envy, doing post-graduation in Emergency Medicine. In this video, we are going to deal with the imbalances in serum calcium concentration. Okay, that is hypocalcemia and hypercalcemia. So starting our discussion with the hypocalcemia. So the definition of hypocalcemia is, it is defined as ionized calcium less than 4 mg per deciliter. Okay, so let's quickly see what are the causes for hypocalcemia. Okay, so the causes are broadly divided into three categories. Okay, so the first one is due to decreased calcium absorption. Okay, it is due to either by vitamin D deficiency, okay, or due to malabsorption syndrome. Okay, these are the two mechanisms for decreased calcium absorption. Second one is increased calcium excretion or decreased bone resorption. Okay, here the mechanisms include either due to alcoholism, hypoparathyroidism, and malignancy, or as a part of sepsis, also in acute pancreatitis. Okay, now there are certain drugs which can cause hypocalcemia. Those drugs include, first one is loop diuretics. Okay, actually the loop diuretics are associated with the hypocalcemia, while the thiazide diuretics will increase the serum calcium concentration. Okay, and the next group of drugs include glucocorticoids, magnesium sulfate, and also phosphate containing drugs. Okay, these are the various causes for hypocalcemia. Moving on to the clinical features. Okay, so let's see what are the system-wise clinical manifestations of hypocalcemia. First one, in the muscular system. In muscular system, we may have weakness, fatigue, spasm, or cramps. Next, in CNS, patient may present with seizures, tetany, Chostek sign, and Trousseau sign. Okay, now there may be some dermatological manifestations like hyperpigmentation, dry, scaly skin, and brittle hair. Okay, in cardiovascular system, patient may have heart failure, vasoconstriction, and there may be ventricular arrhythmias. Okay, like torsades, deep pointers, etc. And in skeletal system, osteomalacia, rickets. Okay, these are the various clinical manifestations of hypocalcemia. Now, moving on to the treatment part. If the patient is having hypocalcemia but he is asymptomatic, okay, then oral correction is enough. Okay, oral calcium correction is enough, and the regimen for oral correction is 500 to 3000 mg of elemental calcium. Okay, is given via mouth. That is for asymptomatic patient. But if the patient is symptomatic, or if the patient is having severe hypocalcemia, then IV correction is recommended. Okay, for IV correction we can use either calcium chloride or calcium gluconate. Okay, but if there is no emergency, non-emergency, if the situation is non-emergency, then calcium gluconate is preferred over calcium chloride, because in calcium chloride the chance for extravasation is high, so there may be calcinosis cutis like symptoms in case of calcium chloride. So if there is no emergency for calcium correction, you have to prefer calcium gluconate. Okay, but if the situation is emergency, then you have to go for calcium chloride. Okay, dosage for IV correction is like 10 ml of 10 percentage calcium chloride, or you can give 10 to 30 ml of 10 percentage calcium gluconate. Okay, whatever, you can give it over 10 to 20 minutes, and you can repeat it at every 60 minutes if the patient is not getting better. Okay, once the patient got better, then you can go for an infusion at a rate of 0.02 to 0.08 ml per kg per hour of 10 percentage calcium chloride. Okay, this is how you have to correct a patient with having symptomatic or severe hypocalcemia. So that's all about hypocalcemia. Moving on to hypercalcemia. Hypercalcemia. Hypercalcemia is defined as total calcium more than 10.5 milligram per deciliter. Okay, hypocalcemia was defined as ionized calcium less than 4 mg per deciliter. Here it is total calcium. Instead of ionized calcium, here it is total calcium. Okay, and it is further divided into mild, moderate and severe. Okay, hypercalcemia is mild if the serum calcium concentration is between 10.5 to 11.9. Okay, if it is between 12 to 13.9, then it is moderate, and if it is more than 14 mg per deciliter, then it is severe hypercalcemia. Okay, then we are discussing about causes. Okay, here also there are three broad causes for hypercalcemia. First one is due to increased bone resorption. Okay, it is seen in hyperparathyroid state, malignancy, renal failure, hyperthyroidism, and in Addison's disease. Okay, the second one is due to decreased urinary excretion of calcium. Okay, it is seen with thiazide diuretics. Okay, and third one due to increased GI absorption. Okay, GI absorption of calcium, and it is seen in vitamin D intoxication, milk alkali syndrome, and in granulomatous diseases like tuberculosis, sarcoidosis, and also in histoplasmosis. Okay, so these are the causes for hypercalcemia. Moving on to the clinical features. Okay, the clinical features of hypercalcemia can be easily remembered by a mnemonic called stones. Okay, bonds, mons, and groans. Okay, stones, bonds, mons, and groans. Okay, the stones means it is renal calculi. Okay, Bonds means osteolysis. Osteolysis. Mons means it's a psychiatric disorder. Okay, psychic mons. And Crohn's means it is due to peptic ulcer disease or pancreatitis. Okay, abdominal Crohn's. Okay, so these are the clinical features, and there are certain ECG features associated with hypercalcemia. They include QT shortening. Okay, coving STT wave, and also widening of T wave. And hypercalcemia increases the toxicity of digitalis in patient taking digitalis. Okay, and also at a level more than 20 mg per deciliter, cardiac arrest may happen. Okay, cardiac arrest, highly prone for cardiac arrest. So these are the clinical features of hypercalcemia. Moving on to the treatment part. So in the treatment part, you can dilute the calcium ions with 0.9 percentage normal saline. Okay, you can give 0.9% normal saline 500 to 1000 ml per hour for 2 to 4 hours. Okay, then you can also give diuretics like furosemide. Okay, so while giving furosemide, caution should be taken to prevent hypomagnesemia or hypokalemia due to the furosemide injection. Okay, and also you can give corticosteroids. Corticosteroids is given to prevent the calcium mobilization from bone to serum. Okay, corticosteroids will prevent the osteoclastic activity. That is the advantage of corticosteroids. And also you can go for hemodialysis. Okay, and suppose the hypercalcemia is associated with a malignancy. So in malignancy, the first line of therapy is nothing but it is IV bisphosphonates. And you can also go for calcitonin. And the dose of calcitonin is like 4 units per kg. You can give either subcutaneous route or IM. Okay, so that's all about discussion regarding imbalances in calcium ions. Okay, hope you enjoy the video, and kindly do subscribe my channel if you are interested in emergency medicine related videos. Okay, thank you for watching.